Good afternoon, everyone. This is Tony Trahan with the Office of Mental Health. I want to thank everyone for coming today on this webinar on promoting healing from trauma. So I just want to give folks a brief orientation to webinars. Due to the volume of people that we do have to keep the lines muted. Please feel free to ask questions via the chat function in the webinar control panel. You can send your questions in at any time, and we will be stopping probably around 2:15 or 2:10 to take questions from you all, so you can interact directly with the presenter. Excuse me. During the webinar, you may experience some momentary lapses in the audio. This is normal and should not interfere with the overall content of the presentation. If you are having difficulty hearing it over the computer, there may be some bandwidth issues that are going on at your site. So you may want to call into the teleconference. The teleconference number is in the welcome message of the control panel, so you can find it right in there. I'm not going to repeat it now because if you can't hear, you won't be able to hear the number. A copy of the presentation was sent out to you all this morning. We will send it out again for people who may have registered late or did not receive it. This webinar is being recorded and archived. We'll also post this with our other recorded webinars on YouTube, and you will receive that link automatically in a follow-up email. Please feel free to share that link with any other people in your agency. We want to get as many people educated as possible. And we currently have 127 people online who are attending our webinar now. We'll probably get some more people as it goes on. When the webinar ends, you will receive a short survey. A window will open up on your computer screen. Please take the time to fill this out. If you need a certificate verifying your participation for credentialing or for your employer, please indicate this in the survey and we will get that out to you. I know that there are probably several people who were on last month's webinar on trauma, and I am still working to get those out to folks. I've got about maybe a third of them out so far. So if you haven't gotten it yet, you will be getting them within the next week or two. Okay? Thank you for your patience on that. So today, our presenter is Janet Chasman. Janet works here at OMH. She was the coordinator of the OMH Trauma Initiative from 1995 to 2005. Since then, she has been the director of the Division of Children and Family Services Evidence-Based Treatment Dissemination Center, which has a strong focus on treatment for youth receiving mental health services who have experienced trauma. And Janet and I have not worked together on many things, but we do see each other quite frequently, and I will say that Janet always has a smile on her face, and every time I see her, it's always a very positive experience, and our conversations in the past have always been very, very welcome, but it's just one of those things. Our paths did not cross very much, and I'm glad that she was able to join us today because I hear that she may be leaving us soon, so I wanted to make sure that she got in here and gave everyone a good webinar on trauma, so we can benefit from her wisdom. So, thank you, Janet. Just give me 1 second. I've got to turn the microphones over to her. So let me just switch these things around. Okay, and you are on.
Okay, great. Thank you, Tony. And I want to thank the Bureau of Recipient Affairs for inviting me to do this presentation. I'm sure for many people, this is not new information. I just pulled together what based on what Tony told me, what I thought might be useful, but I truly welcome your feedback and questions and, say more about this and, just letting us know what you want to hear more about because it is kind of an overview. And again, I apologize if it's redundant for people because I know from the work you're doing, you I'm sure know a lot about this topic. So anyway, let's get started. Okay.
I have a temperamental computer.
Yep, I got it. Nope, I don't got it. Yes, I got it. There we go. Okay.
Let me just close that.
Oh, yeah, close that. All right. I tried to have Tony open up his email so we could see all his personal communications, but he refused. Okay, so anyway, but this very serious topic. Okay, so I thought I'd provide you with a definition of trauma. The first component of having PTSD is that you have to obviously have suffered a trauma, experienced a trauma. A trauma is defined as an event that overwhelms one's ability to cope. It provokes extreme fear, helplessness, or horror, or witnessing a traumatic event is oftentimes traumatic. This is different than what they used to say, which was an abnormal event that that happens to anyone. And really, we now know that these experiences are very common, and most everyone has experienced at least one trauma. For example, most common is a car accident. Okay. Oh, there we go. Okay, so what is PTSD then? Immediately following a trauma, most people experience this, fear reactions, nervousness, and intrusive thoughts, memories when they don't want them. That's actually called acute traumatic stress disorder. But for most people, these subside within a few weeks. If they continue more than once, that's what we refer to as post-traumatic stress disorder. PTSD symptoms, I just want to say a word about the word symptoms. I know some people object to it. Really, for the most part, symptoms are ways that people find to adapt to experiencing that trauma and, the pain that results from it. And so these are adaptations that were helpful perhaps during or immediately following the trauma, but in current day, they're not helpful. And of course, in the mental health system, they call them symptoms. So anyway, the three areas are re-experiencing, which is, reliving the trauma, avoidance, and hyperarousal, jittery, always on the lookout, jumpy, easy startle reflex. Okay, different trauma, different consequences. If you have repeated trauma, many types of trauma, trauma perpetrated by a trusted person, or a more intimate type of trauma like sexual abuse, there's a greater chance of developing PTSD. And remember, on the other extreme, you have a car accident. So, there's a wide range of traumatic experiences, and some of them are can be much more painful, long-range, causing long-range problems. Then there are many people who develop problems beyond the ones I just talked about that look different, like depression, addiction, self-destructive behaviors. This is referred to as complex trauma, and actually there's a group of professionals that are trying to actually get that into the DSM because they feel it's a whole unique set of symptoms that should be recognized and affects a lot of people. Okay, so the Adverse Childhood Experience Study, I know you heard about it the last webinar, and a lot of people have heard about it because it is humongous, huge, 17,000 people in a general practice, not a psychiatric or mental health setting at all. So it's big, and the results are startling, and lots of articles have come out about, the various aspects and information that we learned. So they asked just a few 10 questions about several different broad types of childhood trauma: verbal, physical, sexual abuse, neglect, witnessing domestic violence, etc. And the more types of trauma that someone endorses, the more difficulties they're going to have in adulthood, including physical and mental health problems. So just as an example, this is how they kind of, this is a picture of what might happen. You have a lot of trauma, you participate in risky behaviors, let's say drug use, therefore you develop liver problems, health problems, therefore you have early death. So that's kind of the link that they make. the findings. More than half the people they questioned had at least one ACE, that's adverse childhood experience. Then 25% reported 2 or more. If you had 4 or more, then you were 4 to 12 times more likely to have alcoholism, drug abuse, depression, and suicide attempts. 2 to 4 times more you were likely to engage in risky behaviors like smoking, addictions, unprotected sex. And you were 1.4 to 1.6 times more likely to be physically inactive and severely obese. And I have the reference for that there. The mental health system does not have a good record on recognizing trauma and is responding appropriately. From anecdotal reports from recipients, here's the typical scenario. They were not asked about trauma. If they reported it, they were not believed. If they were believed, they were told it was not relevant to their mental health issues. And certainly trauma and any resulting difficulties were not considered in the diagnosis or treatment plan. Hopefully that's all changing, but as you know, change is slow. So these are the things that probably should be done in the mental health system. Universal screening. In other words, every single person should be asked about traumatic events that they experience. And as we see with the ACE study, they have 10 simple questions. I think there are trauma screens that may even have fewer. So it's not a big deal, and it's not like it's something that everybody cannot do. The symptoms, there needs to be an assessment of any symptoms. There should be universal trauma-informed care. And that's consider the present behavior in light of some past trauma. Think of things that tend to re-traumatize people. Obviously, one might be restraint and seclusion. And really try to avoid that with anyone, just because lots of people have experienced trauma. Even if you haven't, if you haven't experienced trauma, we don't want to start now. And every mental health setting should offer some kind of trauma treatment, meaning helping the person process and cope with the residual effects of the trauma. Some effective trauma treatments, and there are many more. First of all, exposure treatment is up there as one of the most effective, certainly one of the most studied, is really what I should say. In adults, the model used is called prolonged exposure. And if you think of exposure, it's kind of like if you're afraid of heights. They take you to the 3rd floor, then they take you to the 6th floor. Then, they kind of work up with you, and as you have like heavy breathing and sweating, they kind of talk you down. And then, until you're at the top of the Empire State Building, by yourself without sweating, let's say. But, that gradual exposure until you reach your final goal. And with kids, there's a form of gradual exposure that's called trauma-focused cognitive behavioral therapy. And it gives the kid a chance to develop these coping skills and be able to calm themselves down, self-soothe. And then it gives them a chance to tell their trauma story, but not in detail of every second and everything, but in a general way, deal with some of the most painful memories, and also ending with, sort of a positive outlook on the future, what they've learned from it, and how they see themselves going forward. That's been around more than 25 years, studied repeatedly, tried with many different populations.
Excuse me, Janet. We've got a couple of just clarifying questions. Mm-hmm. Could you just tell us again, what does ACE stand for?
Absolutely, and I think I neglected that. That's adverse childhood experiences.
Okay. And then another question is, can you expand a little bit on the sanctuary model?
Oh, yeah. The sanctuary model.
Sandra Bloom, right?
Sandra Bloom. That's been around a long time. Rather than a treatment like a typical mental health treatment that goes after a specific symptom or a specific skill. It's more of a holistic or a milieu treatment. Basically, the part of the philosophy is if staff are experiencing trauma, then certainly are the program recipients. So if you, I mean, for example, if my boss, is critical and kind of dictatorial, I might treat someone I supervise in the same way. And I mean, that's just a simple example. But also, a trauma has a lot to do with how we interact with people and avoiding trauma when we work with them and kind of developing an open communication and a way of resolving problems that does not traumatize or put down anyone. So staff practice that in their everyday work and also promote that with within the people they're working with. And so, there's a greater respect for people, and there's the focus is on your everyday interactions with people, with each other, with the people you're working with, and so that's pretty much what sanctuary is, I would say, in a nutshell. I mean, it's much more involved, and but I think that gives you a good idea. And they're probably the most well-known of milieu treatments or treatments that really talk about your whole environment.
Okay. And there's more. I think there's more stuff on the web.
Oh, you betcha.
As well? Yeah. Okay. So people can Google that.
Yeah.
Okay.
Yeah. Great point. Thank you, and thank you for asking for that clarification. Okay. So now. In general, treatments that have been effective for trauma and actually are effective for lots of different problems that people have are cognitive behavioral therapies. And the concept behind that, and if it's too simplistic, I apologize, but basically thinking, feeling, and behavior are all interrelated. So if you're feeling bad and you change some of your thoughts, you might feel better. If you're feeling bad and you engage in different behaviors, you might feel better. And the three interact and go back and forth. In a nutshell, that's what cognitive behavioral therapy is. Dialectical behavioral therapy, which I know a lot of people are familiar with, is actually a combination of CBT and Zen Buddhism. And that's where stuff like the meditation and, being in the here and now, a lot of that comes from Zen Buddhism. Cognitive restructuring is, literally changing your thinking about something. So, for example, see yourself as a survivor rather than a victim, or, blaming yourself for the trauma rather than putting the blame where it belongs on the perpetrator. Those would be simple examples. There we go. Vicarious trauma. That I think is something we hear less about, but that's sometimes called compassion fatigue. It's the same thing. The idea being if we are working with or even hearing about traumatic experiences and hearing from survivors, we ourselves take some of that in and actually develop symptoms that look like PTSD symptoms. So ways to prevent that. First of all, be aware that if you're working with trauma survivors or you're hearing about traumatic events, it might affect you. It's likely to affect you. Get support from your coworkers and peers because you're all going to be likely to experience that. Look for balance between work and rest and play. And again, that's not something, when we get committed and maybe we get in an advocacy role, it's very easy to forget that nobody can work all day long. Take care of yourself. Again, you can't take care of someone else if you're not taking care of yourself. So get enough rest, get enough sleep, healthy diet, exercise. Do something fun. That is a requirement. Find meaning and connection through whatever works for you, spirituality, religion, meditation, volunteer work, creative arts. Some people like to be out in nature. Not me, myself. I like to be inside. But a lot of people like to be out in nature, and they find that healing for them. So whatever works for you, but you don't want to come away with, oh, my God, life is full of horrible things. There's no hope. And, you know, you want to see the bigger picture. And I just provided a little overview of my current job, which, of course, I love. And I've been in it 6 years, and I think we are doing a lot of good work in the Evidence-Based Treatment Dissemination Center in working with providers of children's mental health services. There's been a number of trainings that have focused on traumatic experiences in children and hopefully resolving them so they do not become something driving pain and suffering for people 40 years down the road. So that's the end of my presentation. I welcome your questions.
Okay, so folks, if you want to send in questions through the chat function, we will have some time to interact directly with Janet. While you all are doing that, I will have a little chat with her now that I have the bully pulpit for a moment, and then I'll get back and over to your questions. So, sorry, I got to leave that up.
Oh, okay.
That's where the microphone is.
Okay.
Janet, so one of the things that I've heard when we work with providers is, you know, a person may keep doing the same things or talking about the same things over and over. It's like, or they may keep saying the same, describing the same incident, traumatic incident or incidents. So what I have learned is that, you know, the way trauma affects the brain, and you can correct me if I'm wrong, is that it knows no time. That this is not something that, you know, it may be frustrating for a provider to talk about the same thing over and over, but the person is kind of still in that place. I mean, trauma it doesn't go from linear, in a linear time kind of thing. Is that correct?
Yeah, they say actually you could do a whole presentation on the whole physiology of trauma, especially the impact on the brain. They have said that traumatic memories are stored in a different part of the brain, and they're sort of emblazoned upon the brain, so that when you're, you know, reach some recovery from trauma, it's not that you forget it happened, but you remember it without the intensity, like you remember anything, like you remember your birthday party last year, or, no, that's a bad statement, but like you might remember some other perhaps unpleasant event, like a car accident that there was no serious injury from. You remember it, it's unpleasant, but you had a little fender bender, and probably for most people it does not affect their lives going forward. Something like that. That's what you want to occur ultimately. But it is stored in a different place, and it's not, and it is a vivid thing. And this is a survival, kind of a basic animal instinct survival mechanism, because, you know, again, if you are, you know, ancient caveman and, you know, you're attacked by a lion, you don't want to just remember that, you know, like you were, you know, you don't want to remember that in a nonchalant way. You want to be super aware that, hey, lions mean danger. I want to be totally remember that when that lion attacked me, it was a horrible, terrible thing. And then the hypervigilance, you want to be on the lookout. So these are all kind of protective, almost like hardwired brain things. So it can be, for most people, it is like it's happening right now. And that prolonged exposure, that's what it does. It kind of puts you in the moment, so it's happening right now. But it makes you go through that story so many times that you ultimately habituate to it or get used to it, and it becomes a less, you know, it's like you're dunked in it, like, and ultimately it becomes like a regular memory rather than this kind of traumatic memory. But what?
So the intense feelings tend to dissipate over time?
Yeah.
Now, is there anything that the person can do to help speed that process along? I think you touched on a couple of things, but any specific sort of examples?
Well, but let me get back to
Okay,
the other point for a minute, because it's helpful to talk about it with a therapist, and for a lot of people, and most people will have to talk about it many times, not just I'll tell somebody once and I'll be cured. No, like on TV.
Right,
No.
right.
But the therapist should be doing more. It's not just talking about it, but it's helping you to, like I was saying, cognitive restructure. You might have some, distorted memories of it. If I didn't say this, or so-and-so did this to me because I did such and such. So there's distortions in there that need to be corrected. There's different ways of thinking about it. There's ways of envisioning the future. Like, it's not realistic to think this is going to happen every day. It certainly might happen again, but you might have some unrealistic expectations for the future. And the other thing that's real important is this being able to self-soothe. You are going to see things that might remind you of the trauma, but you have to be, it's best if you're able to calm yourself down, figure out how to relax, stay in the here and now, all those kinds of things. So a therapist should be doing much more than just hearing this story over and over. But as you say, they definitely have to know they're not going to hear it just once.
Right.
So are there ways to speed it up? The recovery process.
Yeah, because certainly trauma is a great feeling of being out of control.
Yes.
And if there's anything that people can do on their own to help, and I don't mean to minimize this, because it's very difficult. The feelings are so intense that it is very difficult to focus on what you need to do to be well. And sometimes we get so used to our demons, or sometimes we get so used to that it becomes a part of us, and we may not say it, but we may be reluctant to let that go because it becomes a part of our identity so much.
Well, I don't know exactly what to say about speeding up the recovery process. I would say certainly things like here and now stuff, like meditation, is helpful to people as part of treatment, but as on your own as well. Spirituality work has been very helpful for people as a way to calm, as a way to have a positive outlook on the future, bigger meaning, not getting caught up in that one traumatic event and how there's no hope beyond that. There's certainly many things people can read. There's support groups. So there are things. I mean, it's like everything, you have to take it with a grain of salt. Just like you interview a therapist, you don't take everything the therapist says as the gospel, but you kind of consider it with a grain of salt. Same with self-help, same with anything you're reading. But, the more knowledgeable you are, I think you've got a better, a quicker recovery, I would say, sure.
Yeah. I think for those of us in recovery, I think for a lot of us, there's a lot of trial and error,
Sure.
So we try a lot of different things and then try to just figure out what's going to work for us. And I think what's important is to remember, to not get too lost in the day-to-day and details, but to make sure that you understand the bigger picture. So what is it that you're really wanting to do with your life? What role do you want in life? Do you want to be a parent? Do you want to be have a relationship? Do you want to have a job? Do you want to go to school? Those roles, and is what to help motivate, and is what you're doing, is that helping you with the process or not? Because
Exactly.
when we talk to people when they are, and I'll get to the questions in just a second, but when we talk to people who have co-occurring disorders, so if they're also using drugs or alcohol, we as recipients tend not to focus on the addiction. We ask the question is, well, the addiction isn't, for us, the addiction isn't the problem. What's the problem? Is the addiction, is this helping you? It may be helping you with your symptoms. It may be helping you with the voices or the intense feelings to help numb some of that. But is it helping you with what you're trying to do? Because there are plenty of people who have successful careers and are not teetotalers. I'm getting a whole thing with the politicians around here. So that's, if it's interfering with what you want to do, that's the problem. That's
Right,
that,
exactly.
and I think that
You
it's good
betcha.
to keep it in that context.
Yeah. I mean,
folks.
one way to look at it is, I mean, the example you give about co-occurring disorders, what's driving it?
Mhm.
Why is it, why is it that someone might need to get drunk or certainly have a few drinks every day? What's it doing for you? Is it just a lovely little way to relax after a hard day work and doesn't interfere with your life? Or do you have something that you need to keep quiet underneath there?
Right.
And that's the role the addiction's playing. And I think your point is a very good one about what do you want in your future. And these various things, what's holding you back? You want to go to college, get a PhD, and do a certain thing. What's holding you back? Is it a fear? Is it an addiction? Is it, negative self-image? I'll never accomplish anything. I'm not that smart. I'm not saying that's all related to trauma, but it could, certainly trauma could have some of those kind of outcomes. So you want to look at that and, kind of face your fears, as they say, or get some assistance in getting over that hump, because ultimately we all want to do the best we can with our lives and, accomplish what we want to, and that's, what's going to give us a feeling of we've had a good and healthy and happy life. So that's what I think you want to do, step back periodically.
Mm-hmm. So let me, there's more I want to talk to you about, but I don't want to ignore our listeners. So let me, because of the way we've got it set up here, let me just log on. If you could just bear with us for a second, folks.
Absolutely. Can they hear me still?
Yep, we're still on. I just wanted to, because of where the questions are and where my computer's located, I think it's going to be easier if we do it from over on this side.
Mm-hmm. I realize I skipped a page, or I may not have highlighted it, but towards the end of the presentation, I have a bunch of helpful websites that people might want to look at for more information and more details. So, for example, there's a National Registry on Evidence-Based Practices, and that is chock full of all kinds of information. You can search on trauma, but also all kinds of topics are in there. So that's just one. And another thing I wanted to say was that one of the articles on the ACE study is actually called Turning Gold into Lead, which, a child comes into the world with unlimited possibilities, and through trauma, they end up without those possibilities, without those options, with really bad physical and emotional and, behavioral kinds of problems. So just taking away potential. So therefore I think one important area, under the that old adage, an ounce of prevention is worth a pound of cure. There's an organization called Prevent Child Abuse that, again, targets people at risk for abusing children and offers them all kinds of support services. And it has been proven to be effective to produce really great outcomes later in life for kids that receive the services before age 5. So I really encourage people to look into not just prevent child abuse, but all kinds of early childhood programs, because those have tremendous benefit.
So I brought this this page up. Is that the page you were referring to?
That's the page.
Okay, excellent. So we'll leave that up while we're talking.
Right.
So I've got several people who have asked the question, several different folks who have asked the question about EMDR.
Yes, EMDR.
What does that stand for?
It stands for Eye Movement Desensitization Reprocessing. That's what that R is. Not recovery, reprocessing. And the idea being, the reprocessing, let's start there, is, as I said before, you not only tell the trauma story, but you want to reprocess it. You want to process the feelings and what that trauma memory evokes. So that's the reprocessing part. The eye movement is the theory behind it is kind of like by moving your eyes back and forth, you're sort of stimulating both sides of your brain while you're telling the story, and that's helpful in reprocessing the memories. The goal is the same as, you know, the other kinds of trauma treatment. At EMDR, because you are telling your trauma story repeatedly while you're doing the eye movement thing, that's an exposure treatment. So we know exposure treatments work. They're very effective. It's questionable. The controversy is, does the eye movement really add a significant amount to it? And EMDR is effective, has shown to be effective with or without the eye movement. So it's definitely shown to work. It has that exposure therapy part of it. And as I say, the controversy is the eye movement component of it. But it's definitely effective, and I think you can find EMDR therapists out there. They might be more available than people who do something like prolonged exposure. It's also easier. Prolonged exposure is a very painful process to go through. EMDR may be a little bit easier, but also processing trauma memories is not an easy thing to do.
Okay, we've got some good questions here. So the next one is, if survivors tell their story, they will dysregulate, and this could lead to dangerous behaviors.
That is an excellent point. And something I meant to say before, as I said, it's not just the telling of the story, it's what you do with it. It's if the story makes you freak out, you need someone there who's going to help you calm down, come back to sort of your baseline, not leave the office in this frenzied state. Also for people, especially people with mental health issues, telling the story is upsetting. It's going to elevate, you're going to get a spike in your problematic behaviors. If you're using drugs, you might be using more drugs. If you're self-injurious, you might be doing that more. Now, obviously, if someone is having some serious mental health problems that's interfering with the regular day-to-day life in a serious way, you could see an increase in suicidal attempt. So you do need to be careful with it. That's why I would not say go to your best friend and tell your trauma story 100 times. You need to know whoever you're working with, whether it's a peer or whether it's a professional, they need to know, they need to be somewhat knowledgeable, and you don't want to just jump in there willy-nilly. And you certainly, like I say, I think a good example is if you're doing some kind of self-harm, you don't want to just jump in and decide to think about your trauma 100% of the time, and you'll see, that'll probably lead to more self-harm. So you do need to be careful with it. On the other hand, the problem, I think has been a problem in the mental health system is, oh, well, our people are more vulnerable, which certainly one could say someone's more vulnerable if they experience a mental health problem at that point in time, or they're an inpatient or something. But the fear has been, don't mention it, don't bring it up, don't ask, don't tell, because though this population is too vulnerable and you're only going to create problems. No, you might need to go a little more gently, a little more slowly, not dive in, protect against some kind of dangerous behavior, putting your, but if you don't process the trauma in some way, help the person recover in some way, decrease their current symptoms, they're going to have this problem forever. It's likely they could have this problem forever. So you got to find that fine balance.
Well, there's a lot of variables, and I think that it is, I think it's important to let the person sort of lead the conversation, and if they want to talk about it and they're feeling comfortable talking about it, I think that's what we generally encourage here at the Office of Mental Health, is a person-centered approach. I think that we should assume that pretty much everybody who has a mental health problem has trauma, whether that is just the mental health problem itself or the being diagnosed and being part of the system itself, or whether it's something that happened prior to that as an adverse childhood experience. So I think we should always assume that there's some kind of trauma involved, and being sensitive to that is important. People who are engaged in self-harm, just speaking personally, and I think that based on other people that I've talked to with trauma experiences, the self-harm behaviors or the adverse behaviors that we use to cope that may appear to be risky or are risky, but we're trying to adapt and cope in the best way that we can. That's probably going to happen whether we talk about it or not. So if we talk about it at a therapy session, and I'm not sure exactly what dysregulate means, but that may, and the concern is it's going to lead to risky behavior. We're probably already engaged in risky behavior, so I think it's important to just acknowledge and do the active listening. For people who don't know what active listening is, that's an extremely important technique. Motivational interviewing, those things seem to be very helpful in general, but specifically I'm thinking of with trauma folks is, listening to the person, just letting the person be, and allow them to express themselves without judgment. And sometimes we don't really want to hear advice. We just need to talk.
Absolutely.
And sometimes the problem will just solve itself. Or when we hear people, when people call us up with issues and things, a lot of times it's just, I just needed someone to talk to. I don't need you to do anything. I just needed someone to talk to.
Well, Tony, you got a lot of nerve because you brought up like 5 different really good issues that I want to comment about. So if I neglect any, please remind me. But if I could, number one, you said...
I stirred the pot.
Oh, my goodness. Well, you brought up so many different things. One is assume that almost everybody, especially in the mental health system, has had some trauma. I just want to point out that the statistics I showed you from the ACE study said that 50% of the people had at least one trauma. The ACE study only asks 10 questions. So that does not mean 50% of people have experienced a traumatic event. Experts in the field feel that pretty much everyone has experienced it. In the mental health system, we see some horrific traumatic events, or one piled upon the next, piled upon the next. For an example, a kid who's abused in the home now gets removed from the home, another trauma, now gets put in a foster home, now gets abused in the foster home. That is not at all unusual. And that's that compounded trauma that, is so much worse. As far as the self-injury or the self-harming behavior, I mean, the thought is when you start telling that story and focusing on that trauma story, whatever your problematic behavior is going to spike. So if you're already doing self-harm, you'll probably do it more for a while. And, I mean, the idea of the telling the trauma story is that you get over this hump and you process the trauma and you move on. I think, if I'm not mistaken, that self-injurious behavior may need to be addressed directly. Like if you're, for example, like if it's an addiction, you're drinking a lot because you're trying to avoid your traumatic memories. You deal with your trauma. You may or may not still have an addictions issue. You may need to, go to AA or deal with your addiction somewhere else, but you don't have that thing driving it constantly. So if you go to resolve it, you're probably going to have a better chance. So that's what I wanted to say about the self-injury.
Yeah, it's about using those things to deal with the symptoms or the problems. We've got to find different ways to deal with it.
Right.
And what I've noticed, in my work in the field over the years is when we have more of a substance abuse approach, and we speak of abstinence, we don't help the person replace what they were using the drugs for. and to teach new skills and learn new ways of, as I say, learn new ways of being in the world, which is a huge undertaking. But,
That's right.
Having good role models like peers and professionals who also take care of themselves with the,
Gotcha.
through the vicarious trauma, who also take care of themselves, those are fundamental tools, I think, to have at your disposal.
Yeah, absolutely.
So,
Absolutely.
So another question that we have here is, how do you encourage clients with trauma to address their medical health needs when they perceive medical treatment as traumatic in itself?
That's an excellent question. Well, I'm not sure this is my area of expertise. Let me put that disclaimer out there. I think, as I said, everything from a mental health therapist to a doctor to a peer to anyone you're working with, ultimately you are the driver, you are the customer, and the customer's always right. So I think you should feel empowered that you go to a doctor, you don't feel comfortable, you feel traumatized, you feel your boundaries have been crossed. Totally fire that doctor and go elsewhere. Talk to your peers about who they've worked with that they found helpful. Also, in terms of, that's one of those behaviors that was helpful at one point in time, perhaps, and it's not helpful anymore. In other words, you had, an abusive experience with a doctor, and again, there's that lion. Boy, let me stay away from all doctors, and I'm going to be sure, and you will be sure, you'll never have an abusive experience with a doctor again if you never go to a doctor. That's good common sense. I mean, that was common sense at the time. However, for your future health, that's not good. You won't discover your problems, you won't get treatment, et cetera, that's obvious. So your past coping mechanism is not working for you today. And that's part of that cognitive reprocessing and what you're learning as you go forward from the trauma, that there are ways to protect yourself. Perhaps go to a doctor with an advocate or a friend. Spend the first meeting interviewing the doctor and getting a sense of how things are done. And the minute you don't feel comfortable, getting up, leaving, and not going back and not feeling like I have to. So
now, would this be a situation where the exposure treatment might be helpful, where a person would be willing to maybe just go to the parking lot, and just sit in the parking lot and watch people come in and out, and
sure.
or and then go in the waiting room, and then
Mm-hmm.
sort of those incremental steps. Would that be a good example of that?
Yeah, that's a good example.
Okay.
I mean, many of these things can be helpful. I guess I feel hesitant to encourage people to, do some kind of exposure on themselves. Right. I mean, an exposure therapist who's truly talented really assesses all these things, measures them, can really help someone who gets a little too deep in to come back out. Mm-hmm. And so I just hesitate with some of these questions you're asking me. And I realize as an advocate or as a peer, you do have to sort some of these things out, and you are giving a lot of support to people. But so that's why I hesitate a bit. But certainly if someone's fearful of going to the doctor, that's one way. Although, like I say, it's not like going to the top of the Empire State Building. Right. That is probably not going to hurt you, except for, some rare event which we can all think of. But in the most part, there's nothing dangerous about riding an elevator and going up top. There is some percentage of danger in going to a doctor, because there are doctors who are abusive either emotionally or verbally and even physically. So that's a higher level of danger than riding in an elevator. So you've learned from your trauma how to protect yourself, how to make yourself feel secure. So that's a good thing to balance out. But again, it can't go too far where you're actually harming yourself by not seeing a doctor.
Right, because you may have something that could be easily treatable if detected early on, that if you avoid dealing with it, then you're going to have a lot more medical interventions down the road. Mm-hmm. So when you're talking about that, one thing that comes to my mind is the use of advanced directives that I think is certainly good to universally promote with folks. So psychiatric advance directives or medical advance directives, either one, basically it's the same. It's the same principle as, you know, a person marking down. So if we're looking at this question about the medical stuff, having someone write down what's good for them, what doesn't work for them, specific medications are really bad for them. You know, all of that stuff helps people stay in control of the situation, especially if we have mental health problems and we're not really able to communicate well if we're in the throes of our symptoms or we're in the throes of an experience. Having those advanced directives available to communicate while you can't, because people want to help. You know, the providers want to help, and sometimes they're not sure what to do, or they misunderstand what we're trying to say, or they misunderstand our behaviors. So having those advanced directives I think are critical. Mm-hmm. You know, tangentially to this would be RAP plans, mm-hmm. and healthcare proxies as mm-hmm. well. So those are some other
and
tools.
That's a great idea, tools, because that's the kind of thing you want to look at as a trauma survivor. Do you want to spend your time going, oh no, I hope I never have to go to a doctor because this could happen, that could happen, that could happen, and that could happen. Again, there's some truth in there. Maybe exaggerated in your mind, maybe not, but there's some truth there. Hey, here's a tool I can use to really guard against that happening, really lowering the chances of having things done to me that I don't want. Yeah. Yeah. So that's an excellent idea of something to develop.
Yeah, and that is that's considered a legal document, so that should protect you. So, you know, so we can educate. You know, we can certainly educate. As people are asking for some specific things, we can educate our doctors around advanced directives. We can encourage the people in our care or our peers to use advanced directives, and and take a look at RAP plans. RAP plans are a little, you need to look at those a little bit more because you need a certified RAP trainer. But they just Mary Ellen Copeland just recently came out with a trauma and RAP. So. If you went to Mary Ellen's site, there's some stuff on there as well. Someone is saying that they can only see page 12, and that's what I have up. So I don't have up. I didn't think that the site that you were referring to before was on the slides.
Which site?
This was a little while ago.
What's on there is the Prevent Child Abuse New York, but I think the ACE study is on there. Anyway, I would just welcome any questions after the fact. If you want to send them to Tony, sure. And any information I can give you, I'd be happy to do so.
Let me go back. Yeah, I think that was the only thing that had all of the links on it. So,
yeah.
All right. Okay, so here's a statement. So with complex trauma, can one develop dissociated identity?
Oh, you betcha.
Yeah.
Good example. I'm sorry I didn't mention that.
Okay, so to stick on that same topic, so that we were just talking about with the medical stuff, in response to the answer about medical professions, the avoidance of the doctor may not be related to the doctor, but may lead to re-experiencing the trauma, which is why many female rape victims avoid going to OBGYNs. It has nothing to do with medical professional, but with the fear of going altogether. That's a
great point,
yeah.
And that's where. If you have some kind of trauma treatment, I mean, that's what you try to do, is you try to separate the generalized issues from the more specific issues. So that could help there. Also, going with an advocate of some kind could help. But, I mean, that's an excellent point. And that would be one of those reasons why people need, some help in dealing with and processing the trauma, because again, lack of those visits can lead, God forbid, to cancer or something that could be caught early, as Tony said. But that's a great point.
So what's the difference between complex trauma and comorbid disorders, e.g. PTSD and substance abuse?
Okay. Comorbid is simply they occur together. Like you said, PTSD and substance abuse, depression and addiction, they just happen to occur together. Complex trauma is there are these classic PTSD symptoms. You open up the DSM, you look at the thing, and there's these symptoms that fall into the categories of avoidance, re-experiencing, and hypervigilance. Okay, and so if you've got, you know, 2 of these and 3 of those, you have to have a certain number of each of those 3 to meet this psychiatric definition of PTSD. I want to say in our programs and in a lot of professional, in a lot of, I think, better PTSD treatment, trauma treatment programs, they don't focus exclusively on people who meet the exact criteria for PTSD because everybody's different. However, the complex trauma is where you have other symptoms not listed in the DSM, like those specific ones I said, but like self-injury, dissociation, depression, some people develop some psychotic symptoms sometimes. It's very hard a lot of times to differentiate between the re-experiencing, in other words, flashbacks, and psychotic symptoms, right? You're hearing voices, the person's not there. Is that a flashback or is that a psychotic symptom? But people can develop all, originally they thought, oh, the only mental health symptom you can develop after trauma, aside from PTSD, is depression. That's it, period. And now we know that it's much broader than that and depends on a lot of things and a lot of individual differences. So that's complex trauma. It looks like a lot of different things, and it doesn't just look like, you know, somebody walks in the door and tells you, you know, you talk to them for half an hour and you know, hey, this is PTSD. No, it can look like a lot of different things. It can take a little while to sort out.
So here's a question. I'm going to try and interpret it as best I can. So they're talking about hypervigilance.
Yep.
And it says that some clients have not developed that, but move from trauma to trauma, hoping each relationship is better without really developing safety features. What are the recommendations for this?
Well, that's an excellent point. In fact, there's data that says rape victims, the best predictor of a future rape victim is someone who's been raped before. Because in addition to fight or flight, which you hear all the time, in other words, there's the lion, you're either going to decide to fight him with your harpoon or whatever, or you're going to run away as fast as you can. There's actually a third component there, which isn't recognized often, which is freeze. Yeah. People are freaked out. Here's a danger. And instead of saying, wow, this is a danger, I better get out of here, they freeze because they're like, oh, my God, the last time this happened, here's a trauma that resulted, and they may freeze. So that kind of makes them more vulnerable to have this trauma happen again. Also, it's taken, for some people, they say, geez, it's almost normalized, and I'm sure this happened before, it's going to happen again. I have no reason to think it won't. And so people put that can happen to people. The other thing, and again related to the ACE study, is risky behaviors. So you've had a trauma, you've got some risky behaviors. One of those risky behaviors is going out to bars and drinking, especially for women, but men too. You go out to bars, if you get very intoxicated, perhaps you make you're more vulnerable if you're intoxicated. You cannot protect yourself as well. You may make bad choices about who to leave with or who to befriend. That person may or may not be safe. You know, and it's true for men and women. I mean, walking down the street home from a bar when you're extremely intoxicated, what are the chances you get run over by a car, beat up, mugged, et cetera, et cetera. So that's another way that trauma leads to a risky behavior, which leads to something dangerous or another trauma happening to you, and it becomes cyclical.
Do you have any experience in working with Indigenous Native Indians who have experienced abuse from residential schools and or any experience in working with any Indigenous Native Indians?
Personally, myself, no, I do not have any experience doing so, nor am I a clinician. Let me make that clear. I don't think I did at the beginning. I know some of the trauma treatments have been tested with people from various cultures. But like every kind of treatment, it's got to be culturally competent. You know, somebody's got to know that culture, or at least be willing to be educated about that culture and what various things mean. For example, in OMH, in many mental health settings, they talk about comfort rooms. In an inpatient setting, having a comfort room where somebody can go, they can meditate, they can calm themselves down and really self-soothe. And it's a very positive thing. One particular program does not have comfort rooms. It worked with Asian women. During the war, prostitutes were called comfort providers or comfort women or something. They could not use that term comfort because, you know, it had a bad association in that culture. Who would know that? But you got to be open to learning those things. So they called it something else, meditation room or whatever. That's a very simple, you know, simple example, but it's a good point. One size does not fit all when it comes to culture. That's absolutely for sure.
So here's a good one. How do we get providers to be more trauma-based and use trauma-informed practices more?
Talk to them. Hopefully we have many people on the line who are peers, not only peer support, but advocates. And this is an area that advocacy and advocates and peer advocates have played a tremendous role. Back in the mid-90s, where the word trauma was never spoken, again, and that's where you bring it up and they tell you, you know, you imagined the whole thing and, you know, all those things. For example, Kathy Lynch is a pioneer in the world of trauma and getting professionals to really pay attention to it. We need, you know, OMH can provide some training, can talk about it. Commissioner Hogan talks about it frequently and really recognizes it as something that is oftentimes driving the mental health issues. But still, you know, people went to school, they were trained a certain way, that's how they practice, they learn as they go, different people are open to different things. We need the advocates out there asking for more, talking to agency directors and telling them this is what people need, talking to their county mental health directors, the New York City Department of Mental Health, and raising this issue as much as possible, and really, holding providers' feet to the fire in terms of this is what we want. You're trying to do evidence-based practices. Well, here's an area. There are evidence-based practices that you can use, and I think that's the biggest thing we could use is advocacy. Just more and more advocacy, and also choosing providers who do have expertise in trauma. Again, there is a little bit of a market issue going out there. If people want to go to X provider because they are offering some trauma treatment and they don't want to go to this other one, people might wake up and take notice and say, look, this is something we all need to offer. So this is an area where those advocacy efforts are greatly needed.
Yeah, I think if you don't have a peer working in your agency, you may want to think about that. Peer specialists and people who have been through this can probably help you with the environment or with some of the approaches. They can probably help educate the staff on some of the more common issues and some of the more common problems. Now, the one about the comfort rooms was good. I don't know that something like that would have gotten caught. It's a little outside. It's a little unusual. I don't think many people would think of that. But if you did have someone on staff who had that personal experience, they would be able to tell you right off the bat. So for people who have experienced trauma, going into the way it's going to be different for everybody, but there are some generalities, and there are some general things that I think can be done to be helpful. And one of the quotes that I'm thinking of is, people don't care how much you know until they know how much you care. And I think that message is important. There's it's a very complex thing. It can create a lot of stuff. We haven't talked about like transference and countertransference in a long time. I don't remember. I remember that from the old days, and it's a very complex issue. But I think there are some things that you can't go wrong. You can't go wrong by not judging people. You know, if you're not judging people, I think that's an absolute universal criteria or universal helpful tool. I think that listening, active listening, is absolutely a universal helpful tool. And there was a third one that I used to say, but I can't remember it now because I'm getting old. So, but I think those are two things when you don't know what to do. Those two, you can't go wrong with those two things.
Yeah. Other things, you know, we have a program in trauma-informed care, and after working with people for a year, people went up to the trainer and said, the therapy aides working in the program said they feel so much better about working with the people because they're seeing the people in their program in a much more positive light, and they have a better understanding of the people. But the other thing they said is it's helped them cope with the trauma in their own lives and understand themselves better. And the other thing, which I sort of mentioned with the Sanctuary Project, is this parallel process. You cannot have staff, especially therapy aides, who feel disrespected, disregarded. Nobody cares what we think. We never get a break. We never get a lunch hour, and we get the poorest pay and the least respect, but we spend the most time with the people on the unit, and expect them to come in and be caring, compassionate, and everything else. It just often spills over, and that importance of having everybody treated with respect, recognizing that most of us have experienced something damaging, and we all need some kindness, and, it's like pay it forward.
Mm-hmm.
You hold the door for someone, they hold the door for the next person, and so on and so forth. Anyway, oversimplified example, but, we've got to think about it in a bigger scale, I think.
Okay, so another question we got is, Medicaid clients can't afford specialized care. Specialists embedded in existing programs could serve a role if OMH lets us, which may be a bigger issue.
Mm-hmm. Yeah, absolutely. I mean, that's been the problem. People in the past, the trauma experts were these private practice people who, don't take Medicaid or Medicare and charge a fortune. And the effort of our office, and I think of, in the adult division, there's a lot of focus on reducing restraint. One method of reducing restraint that's really been embraced is trauma-informed care. We want to see those skills in the public system accessible to everyone, not just those who can afford it.
So one thing I wanted to mention, we got some more questions here, but one thing I wanted to mention was, I work with the forensic folks a lot, and I think it's important, because that risky behaviors can lead you to jail,
Yeah.
And drawing the attention of the authorities. So, the thing I think that is important to remember, and I think I may have said something similar to this in the last trauma webinar, is, I think it's important to remember and remind people that they've been through something terrible and that they are resilient. They've gotten through it. They've found ways to adapt and cope and survive. And that's huge. It's, they are very strong people who've gone through some very unusual and terrible and terrifying things that they were able to get through. And that, oftentimes, as we said, these things happen in our childhood. So the skills that we learn to survive are absolutely appropriate for that period of time. But then when we grow up, those same skills, and we get into the so-called normal world, or in the society in general, those skills are no longer applicable. And I think that we as providers will see that those behaviors, come out. And remember that these are the things that people learned in order to survive, and they've been successful with that. So rather than, sometimes it's easier to try to change the world to make it so your skills are relevant, which can be incredibly frustrating and difficult for providers to create, if someone's trying to create a chaotic environment where their skills are relevant. is they've got to learn new ways of being in the world. People need to learn new skills. So I just think that it's important to remember that as we work with people with trauma issues, to make sure that they understand their self-esteem and their role in this, and that they've done some really great things to survive. And now it's time to take that resiliency and that strength and that courage to a different place, and so you can be successful as an adult and do more than just survive, but to actually live.
Mm-hmm. I mean, we have all learned that telling people, just say no, don't do it, has not been effective for people who self-injure, for people who drink, for all kinds of issues. And in fact, it's true that to have survived some of these things, you do have to be a strong, resilient person. And some of what you used to adapt is not working for you right now, but you needed that. And what was very good that you developed it, because it helped you get through it. So you're not even being disingenuous and just giving a person a phony, compliment to boost their self-esteem. You're actually saying the truth. Mm-hmm. And in DBT, which stands for dialectical behavior therapy, that dialectic is two things that oppose each other, but they're both true. And that's what it is. We accept you. We understand where you came from. We understand why you have these behaviors, and yet at the same time, you need to change them. And they're both true. One does not, one is not more true than the other. They're both true. And that's what we all have to learn in our lives, There's not always consistency in things that make sense. And, it's a little bit, it reminds me a little bit of the serenity prayer. Mm-hmm. Accept the things you cannot change and change the things you can. You can't go back and change your childhood. Mm-hmm. But it's there. You see it. It happens. And now you change the things you can and going forward and doing the best you can.
Yeah, you can change how you let it affect you. And, it's one of the things, I think another aspect to trauma that we haven't talked about is anger. There's a lot of anger, and there's a lot of a sense of revenge, that you want to get revenge on the abuser. Somebody said something to me once which was just so profound, is you want to get revenge, live a good life.
Yeah, that's
right.
The
best revenge that you can have on somebody. Stop letting them continue to victimize you by you victimizing yourself and not allowing yourself to grow and move out of this phase and into the next phase of your life. So that's something that has always stuck with me. So we'll do a couple more questions. So in multi-trauma families where patterns are repeated, what kind of legal aid is available for the children in the families that are repeating the patterns? So, so a family, so if I understand this, a parent or parents who have trauma issues are repeating them as they now have children themselves, mm-hmm. which is common.
Oh, it sure is. But the law doesn't make a distinction between if you've experienced trauma or you haven't. If you're abusing a child, there's the child protective agencies that are supposed to protect kids. They're supposed to, anybody can report a case of child abuse. Certain people, professionals, are mandated reporters, as I'm sure you all know this. And then an investigation is supposed to ensue, and findings and help or counseling or, some kind of remedy, some way to help the abuser stop abusing, or, legal, depending who the abuser is, might be a legal order to stay away from the victim, or ultimately taking kids out of their homes. And that's certainly not the first choice, and it can be traumatic for the kid too.
Absolutely.
But if a kid is getting serious, if a kid is getting abused in the home, they may need to be taken out of that home. So there's that whole, those are the laws. But they don't, like I said, the law doesn't differentiate between if you've been abused and if not. An agency like a Prevent Child Abuse may look at, you've had an abuse history, you may be more likely to abuse, let's help you out in working with that as you get that new baby, and working with you from 0 to 5 or 0 to 3 of that baby, and you learning a better way to deal with that kid versus how you were raised.
Yeah, and just this is just my personal pontification. So children, it's illegal to harm children, not only on a law level, but on a moral level. And if anybody does suspect that, it is very important to report it. And it may be as you said, a mandated report. It may be required. When we look at what happened with Penn State, and where the report went and nobody did anything, or people knew about it and didn't report on it, based on what's coming out now in the I think the Freeze report. These are things that if we are silent, we contribute to it. To it. So if we have that suspicion, we need to make sure that we let people know. And I actually had a friend that used to work there, so they will, they know what the signs are, and they will, see if there's anything to this, and then they will follow up based on what they think is the right thing to do. So the values change. I think, if children are being harmed, then the goal is to keep the children safe. And I hate to sound, again, it's just my opinion, so I hate to sound editorializing here, but the goal is not immediately is to keep the child safe. It is not to protect the feelings of the parent. That can come later, but they've committed a crime. So
absolutely. And I think that you mentioned an important point that I just wanted to highlight, which is suspicion of child abuse. You don't have to feel like, oh, I know for 100% sure, I think this is happening, but geez, maybe it's something else. It's not your job to investigate it. If you've got that suspicion, report it. Maybe the Child Protection Agency finds out, no, it isn't the case, but you've done something good. You've looked into it, and you've made sure.
Yeah, because and it's up to them to figure out, because people can abuse that line or misuse that line, especially when there's separations or divorces. They can accuse the spouse of abuse and things like that, erroneously. So, if you feel that way, then that's why we have this in place to sort of filter out some of that stuff. And these people are experienced, and kudos to them, because it's got to be a terribly difficult job. I know there's a lot of turnover there. So
a lot of vicarious trauma.
Yeah. All right, let's go to another one. So there's a couple of other things that people are bringing up, a couple of other tools. So they're talking about EMDR, and then there's another one called We Teach Rapid Grounding Using Bilateral Stimulation. I'm not familiar with that.
Yeah, but
I'm familiar with grounding.
Yeah, bilateral stimulation, unless you're talking about something different, and but I have heard that term used similar to EMDR. In other words, how they wave the finger between right and left, is called bilateral stimulation. And it doesn't have to be used with the finger. I've heard of, they have earphones, and alternately it makes noise in each different ear. So you're going back and forth between the parts of the brain. I saw a question in there, actually, when I was perusing it, about can OMH facilities or OMH licensed programs use EMDR? There is no regulation. I think I'm 99.9% sure. There's nothing in OMH that says you must do this type of treatment, you must not do this type of treatment, except I think there's a rule against aversive treatments. But there's almost no rules about what treatment you can and can't use. So it's probably a program or facility decision about what they will support. But something like EMDR, there is no rule against it, and nor is there somebody from OMH saying, oh, we want everybody to use EMDR. But as I say, there's almost no rules about any type of treatment a program can or cannot use.
So someone's giving us some information. It says in New York State, there's also the Crime Victims Assistance Bureau that will provide funding for therapy, medical interventions, transportation, court advocacy for victims of crime, for sexual and physical abuse. So there's that's available.
That's a good point. I'm so glad you brought it up. The other thing I want to mention is rape crisis centers. We all know them as somebody's raped, they call, they get an advocate, goes down with them to the hospital emergency room and gets the physical testing done and stuff. Rape crisis centers usually also offer support groups and ongoing counseling of some kind. So they may be a really good resource for people.
Okay. Several years ago, the OMH medical director sent out a memo stating that EMDR should not be used in OMH facilities. Has that stance changed? I don't know.
Remember, it was a memo and not a regulation, rule, policy. And as I'm trying to remember back, I know for a fact a decision was made not to use OMH funds to support training in EMDR. That's what I recall. But you may be, you may be right that note did go out. But as I say, it's not a regulation, and the personnel has changed. I don't know that anybody else has really looked at EMDR, made a decision one way or the other about it.
I think it's important to remember that we need to be eclectic, and that no one thing is going to work for everybody, and that we should, whatever seems to work for somebody, one person is not going to work for another person. Overall goal, and I hate to beat a dead horse, but overall goal is how is this supporting that person's, living of a good life or having a life that's worth living.
That's right.
So, and that, we are, as recipients and as patients, we have to be careful. We have to be careful not to get too caught up in a victim mentality. We have to make sure that we don't get caught up in that. We have to make sure that we don't get caught up in learned helplessness and codependency. We have a responsibility too. It's going to be a lot of hard work. But again, we couldn't control what happened to us, but we can control what we do now and the choices that we make now. So we have a responsibility as well to, I don't want to portray people as helpless victims, because they may have been at one time as children, but now that we're adults, we do need to take responsibility for our lives, and we'll overcome these things. We'll overcome these things.
Yeah, and in addition, people have shown tremendous resiliency, as you said before. These treatments are not easy. It is not easy to do some kind of trauma exposure. It's painful, it's difficult. DBT, that's not easy either. Accept reality as it is, do these things, cope with these difficult memories, difficult feelings, difficult emotional states. It's not easy and it's not painless. And if you have accomplished that, you've accomplished a tremendous amount. So I just myself don't take it lightly when somebody is dealing with some trauma symptoms and has not yet gone in and done some of these different things, because it's scary, it's difficult, it's challenging. You do need that strength to do it, and you have to do it when you're ready.
Absolutely. Absolutely. So one other question here, and then I think, let me just check the time. Okay, so we'll do one more question. So once you have taken DBT, would you suggest that the person find some way to incorporate the processes into day-to-day life to keep them in the frame of mind that would lessen the trauma?
You bet. And that's exactly what these are, daily practices. Well, the one big component of it is meditation. And as soon as a professional gets trained in DBT, they have to do meditation, because it keeps you grounded and it manages, some of your emotions and things like that. It's probably like AA. If you're an addict, you may be able to stop the drinking for a while, but you may need that continuous support of AA. And it's the same thing, DBT, and like a lot of therapies, you learn skills to use to help you. Probably over time, you may need to actually implement those skills a little bit less. But you've learned skills which you can use. That's what we want. We don't want people to have to be in a hospital or under, constant treatment.
Right.
We want them to learn skills that they can then go out and use. And let's face it, everybody in life, whether you have a diagnosis or not, has something they do to, to get through difficult times, bad news, stuff that's out of your control. Everybody's got something, good, bad, or ugly, whether it's drinking, whether it's exercise, whatever it might be. And that's what we all need. And the more serious difficulty that you have faced, probably the stronger coping mechanisms you're going to need, but you need to take them with you in life.
Absolutely. So
That's a great point to end on, I got to say, very positive.
absolutely. So, thank you everyone for coming today. Thank you very much, Janet. This has been a wonderful, it was a very dialectical kind of webinar, which was appropriate. Next month, our webinar will be on October 17th, which is also a Wednesday, and that'll be from 1 to 2:30. That we will have our friends from Center for Practice Innovations will be joining us, and they do a lot of training on evidence-based practices. So their major components for training is the FIT, which is Focused Integrated Treatment, and that is for the co-occurring disorders. They have the ACT Institute, Wellness Self-Management, which is based on the Illness Management and Recovery Evidence-Based Practice from SAMHSA, and Supported Employment, I believe, is the third one, or the fourth one, excuse me. So they'll be joining us, and they'll be talking about what they do, and I think they'll be talking about how providers can access those trainings as well. They have been disseminating and working with our facilities and as well as our community providers. So it's basically be a good promo for them to get the word out on who they are and what they do and what they have available for you.
And they have a brand new module on co-occurring disorders in adolescents.
Excellent. Cool. Well, thank you again very much. Again, when you close this out, there will be a window that opens up with a little survey on it, about 4 questions. If you could just fill those out, that would be great. And thank you again for joining us, and we'll hopefully see you next month. Bye, everyone.
Thank you so much.